So moving on from measure to reduce, I think this is the hard part. We've made great headway in the identification and measurement of low value care. I don't think anyone has done anything more on a statewide basis than Beth in Virginia. I include on this slide a list of levers that Michael Boudros and I included in an editorial in the American Journal of Managed Care. There are lots of ways for us to consider potentially the reduction of low value care. Since there's been so little real world implementation of these levers, I can't tell you personally from an empirical or database type decision which ones would be most effective. As someone who's worked pretty much on the patient-facing side in my career in benefit design reform with value-based insurance design, it is my impression as we go into the evaluation phases that most of the utilization of low-value care is actually provider or supply-side driven, with few examples notwithstanding, and that it's the levers on the left side of this slide that I believe to be most impactful in the reduction of low-value care. I have argued for a decade that alignment of provider-facing or peanut butter and patient-facing or jelly incentives are the way to get more value out of the healthcare system. I think they're more equally rated on the way to get more people to get high-value care. I'd like to think going in that the levers that will have the most impact in reducing low-value care will be more on the provider or peanut butter-facing side. Next slide. So I'll leave you with this. I hope some of you at least know of Section 2713, which is the part of the ACA that requires us to cover high-value preventive services at no cost to our patients. In our work in the ACA around clinical nuance and value-based insurance design, there is another section that I believe that none of you have ever heard of, which is Section 4105, which clearly states that the Affordable Care Act grants the Secretary of Health and Human Services the authority to eliminate coverage for U.S. preventive services, D-rated services in the Medicare population. This includes prostate cancer screening over 70, as I mentioned, and also colorectal cancer screening over the age 85, and there's a few others. But why I bring this up to close my remarks is there is already regulatory guidance to help you, purchasers, whether you use the D-rated services in Medicare as described by 4105, or the D-rated services that apply to a more commercial or a Medicaid population, that this, in my opinion, is the easiest place to start. The same organization that provides you one of the most popular aspects of your benefit design, that being those services that are A and B rated by the task force, also on occasion will identify services that should not be prescribed at any price. And it's been my challenge now for many years to identify a plan that is willing to move forward either through supply or demand side levers to try to reduce these no value services in a way that will hopefully free up some additional dollars for us to be able to purchase more services that improve individual and population health.